Okay, it seems that we are live, and thank you very much for continuing to participate in this discussion today. It's a glorious day, so it's a challenge to you to stay screen bound and continue the discussion. We have 4 panelists and 2 special guests, and I'd like to ask them to introduce themselves just shortly. So let's start with you, Kingston.
So I'm Kingston Mills. I'm Professor of Experimental Immunology in Trinity College Dublin, Director of the Trinity Biomedical Science Institute. I'm an immunologist with a special interest in vaccines.
Okay. Sam?
So thanks. Sam McConkey is my name. I'm Deputy Dean in RCSI. I'm a sort of hands-on clinical infectious disease, tropical medicine and general internal medicine doctor for 31 years. So I guess I'm approaching a lot of this with a physician's hat on. My research interest has been in phase 1 clinical trials and phase 2 and 3 clinical trials, mainly of new vaccines, including first in humans of some, I don't know, adenoviral vectored vaccines in Ireland in recent years.
Okay. Maria?
I'm Maria Baghramian. I'm a professor of philosophy at University College Dublin, and for the past 5 years I've been working on various research projects on the question of trust in experts and expertise.
Dónal?
Hello, I'm Donald Mahoney. I'm an associate professor recently at Dublin City University, but now at The Ohio State University in the US. And disaster and pandemic ethics has been my research specialism, and I've been involved in the scarce resource and the vaccine allocation committees at the Ohio State's Medical Center.
Okay, Nick, we have you.
My name is Dr. Nick Flynn. I'm a GP in Cork City. I'm a GP trainer with Irish College of General Practice, and I chair the National Coordinating Committee for GP Training. I have a particular interest in, I suppose, vaccine delivery. I'm the GP representative on the local HSE steering vaccination steering committee.
And Simon, finally.
Hi, my name is Simon Mills. I'm a senior counsel barrister, former doctor once upon a time. I am one of the authors of a book called Medical Law in Ireland, and as unlikely as it may seem, I'm no relation whatsoever to Kingston Mills.
Okay. Well, just for sake of completeness, my name is Bertrima. I'm a professor of virology in Queen's University, by now retired, but still quite active in many ways. I have been involved a lot in the whole debate on MMR and autism since 1994. So there's a long stint in questions about vaccines and vaccine safety and so on. So the first question that we want to discuss as a panel is what benefits and risks are presented by the vaccines at the individual and the public health population level. And so maybe Kingston, you can start with that discussion of that, and then I'll call on the others if they want to raise their hands, what else they want to add. Kingston.
I think after clean water, vaccines have probably had the biggest impact on human health. Certainly from a medical intervention point of view, they've had the biggest impact on human health. We've eliminated smallpox, almost eliminated poliovirus from the globe, significantly reduced huge numbers of other infectious diseases, diphtheria, tetanus, whooping cough, measles, rubella, and the latest one, of course, human papillomavirus, which causes cervical cancer. So the success story of vaccines has been tremendous. The risks, on the other hand, are there. Every vaccine has side effects, and that's why we have phase 3 and phase 1 and 2 clinical trials to assess those risks. Those trials can pick up risks sometimes after the vaccine has been licensed in post-licensing surveillance. Other risks can be picked up, and a very good example of this is the clotting issue with the COVID-19 vaccines. These weren't really picked up on the phase 3 trials simply because they were too small. They were the right size in 10 to 20 or even 30,000, but the case numbers that the risk was in the hundreds of thousands or even million, 1 in a million in case of the Johnson & Johnson vaccine. So these risks are very rare, but they're probably real. I think what everybody has a right to do is to weigh up the data and with the help of experts interpret that data on the benefit versus the risk, and then make a decision whether to vaccinate or not. In most countries, including Ireland, vaccination is not mandatory, and the public have a right to make a decision as to whether to vaccinate their children if it's a pediatric vaccine, or take it themselves if they're an adult. And that information must be based on accessible data that are provided to the public. There was a situation about 10 years ago with a pandemic flu vaccine where a number of recipients got narcolepsy, and that ended up in the courts. And one of the big issues was around the information that was given to parents of the children that got the narcolepsy. So that highlighted the importance of very clear, unambiguous information given to all recipients, whether they be adults or the guardians or parents of children that get the vaccines. Related to this, I just bring up the issue of trust in the information that's provided. I read only 2 hours ago an article that was published on the Sky News website, and I'm just reaching for the headline. And it says, COVID-19 risks of blood clot after coronavirus is 8 times higher than after AstraZeneca vaccine study. I then went and looked at that's a misleading heading, and that's coming from a reputable source. I then looked at the actual source from the group in Oxford that published this, and what it said was there were 8 times higher risk of getting clotting from the disease than there was from the vaccine. That's absolutely true. But it failed to say, of course, is that only 5% of the Irish population got COVID-19, and we hope that between 80 and 90% of the population will get the vaccine. So you're not comparing like with like when you're saying that there's 8 times more risk. So that's the sort of information that needs to be qualified by experts, that is put in the public domain by reputable sources. I'll leave it at that for now. I'm sure the others will want to come in, and I come back in again.
Anyone else who want to come in? I mean, raise your hand if you want, or Sam.
Thanks. I think the sort of soul searching in both individual souls and in our national discussions around risk that we've all been having in the last 3 or 4 weeks, to me are part of a much bigger kind of generic issue of sort of what it is to live in the modern society, where we have lots of sort of technology interventions and lots of public sector tools to hopefully help us live life better. But whether it's, the famous Dublin bus that, drove up on the pavement up near Christchurch and, almost mowed a few people down, or whether it's a vaccine, every bit of technology and intervention has risks and downsides to it. And so some people find that difficult in their life. Their way of thinking about who they are makes it difficult to sort of embrace or acknowledge any degree of risk whatsoever. Some people are intrinsically risk averse and almost find it pathogenically frightening in their soul to even conceive of that there could be any bad thing associated with X, Y, or Z. They just cannot tolerate any even small X, Y, or Z risk. And then, of course, what does 1 in a million mean? Now, those of us who are gamblers on the Irish Grand National and maybe won a bit on 150 to 1 in Fairyhouse know that 151 odds is actually really hard to win on, and you should be really happy if you had a fiver on that horse. And as for 1 million to 1, that's less than winning the lotto. But a lot of folk are not gamblers, and they don't have that maybe quantitative way of balancing one thing against another. So a lot of it tends to be, as we've just heard from Kingston's example, an emotional headline on a front page that sort of says a number, but people are interpreting that number in a maybe way that is more emotional, and maybe the facts behind the number are not actually reliable. So I think we're part of a much broader question of how to live in the modern, postmodern world, where every conceivable thing that we touch and do has a risk, from a mobile phone to a bus, to a train, to a vaccine. So there's a lesson, this is a lesson in growing up and accepting that we are in a risky world, and for people psychologically who struggle to cope with that, to find ways for the rest of us to help them to cope with that. Now, whether that's through friendships or music or dancing or hugging or diversion or whatever, I don't know the answer, but we have to be sympathetic to those among us as humans in our community who really struggle with this idea of having even a risk of 1 in a million and saying, well, that might be okay for me.
I think all the questions really relate to that particular base question, is that risk perception for the public is extremely difficult, and people find it very difficult to translate one risk into another. And that is something that that we obviously are confronted with here. I see Simon, you want to come in?
Yes, but ultimately, I think to say something quite similar to what you just said, Bert, which is that one of the things that clinicians know and scientists know and public policymakers know is that people are really bad at understanding risk and also at plugging the gaps in things that they do not know. And that can lead people to make wrong judgments. And when I say wrong, I mean that they can make guesses about risks that are wildly inaccurate. So almost baked into the idea of the ethical obligations around things like vaccination or communicating about COVID-19 is the obligation, A, to communicate in a straightforward way about risk and as clearly as possible, and to understand ourselves that in the absence of the most careful and minute explanations, there will be difficulty in understanding very complex issues about risk.
Mm. I think particularly the distinction between risk for oneself and risk for the population is something that obviously is an extremely difficult question for most people. Any other comments that anyone wishes to make at this stage? Maria?
Yeah, so I have a similar point, but I think I'm coming to it from a slightly different perspective, the perspective of cognitive scientists. So studies show that when there are high emotional outcomes at stake, people just ignore probabilistic reasoning. It's not that they are not well informed. So it's not a question of teaching them to do better. The point is that this is part of our human psyche, whether for positive outcomes in case of hope of winning the lottery, or negative outcomes like fearing death from blood clotting. We, as Cass Sonstein has pointed out, we engage in probability neglect because the harm that's facing us outweighs it. So that's one point. And secondly, in such cases, we rely on heuristics and biases in our reasoning. So heuristics just means like thinking in terms of rules of thumb. And those heuristics and biases makes us think of the most relevant and proximate event to our own personal life. So if you have had a friend who has had an adverse experience with a vaccine, that will have much more weight in your thinking than any probability account and explanation that doctors might give. While on the other hand, if you have a friend who has had the vaccine and is now going out to pubs and so on, that will have a much more positive impact. So in a way, it is personalized thinking that helps rather than more education and trying to enforce rationality on people where rationality would not go.
I think overcoming the availability heuristic is a really big question for people. Any other comments that anyone wishes to make on this particular question? Nick, yeah.
Thanks, Bert. So I thought Kingston's introduction was very interesting about the importance that vaccinations have played, I suppose, in the evolution of medicine and in our own evolution as a species. But we still have to remember that while vaccination programs in the first world have been very successful, we still have 2 to 3 million people dying worldwide from vaccine preventable diseases. And so very much while we're focused on COVID-19 as a very significant illness, and still I think is 1.3 million is the worldwide mortality as we stand. That we have to bear in mind that the problems that we're having are very much our first world problems in access to the new vaccine, and vaccines that have been around for 30 and 40 years still don't have penetration throughout the globe. And I think from an equity of access to healthcare is something that we should consider.
Yeah, sure. Okay. If there's no real further comment on this, I think I'm sure we'll come back to this particular question. Is the next question I wanted to discuss with you is this: how to distinguish trustworthy sources from unreliable or fake sources? And I'll go to Dónal because of his sort of involvement with Cochrane. And so, Dónal, how do we do this? How can we actually use that particular type of information and bring it to a greater public than it gets at the moment?
Well, I think you're getting at the importance of people at all levels being able to examine and review and kind of digest the information that we're getting. And I think some of this starts with basic sort of, I suppose, reading skills. So like Kingston's example of the headline, that we need to communicate to people that when you see a headline, your first reaction should be kind of like, where's that coming from? What's underlying it? And then having ways to dig a little deeper rather than taking it at face value. And I think those types of skills or approaches to media of all sorts need to be introduced and, at all levels of education, at whatever level of introducing science and in elementary schools and, up through secondary school into the universities, professional training. And, that's something that Cochrane as an organization does on the professional level with the peer-reviewed publications, but then making sure that that disseminates all the way down so that, for example, busy bedside clinicians are not going to be able to spend hours going through randomized controlled trials, but having well-conducted syntheses of that literature for them, having that available readily, and then taking the time to keep up to date with whatever particular area of practice is most close to your hands and your fingers. But I think going all the way down then as well, that we as people who are involved in academics and practice can, we have a role to help, I guess maybe translate the peer-reviewed data into forms that can be understood by people at all sorts of different levels. And so, for example, I was asked by my church leadership to write something on the safety information around the vaccines. And I was really surprised by a lot of the information on medical center websites and even professional bodies that was very much kind of like, oh, sort of, don't worry, these things have been well tested. You can trust the research process, but really didn't provide very much of the details. And I think that's where, if those who do have the expertise are not providing at least links to the raw data, so to speak, then when somebody else gets up and says, well, I don't think this stuff is trustworthy at all, their message is sort of on a similar basis. And so when we do communicate, like Kingston did, being able to go back down and say, well, there is this reliable information that you can access, providing links to it if it's something we're writing, that helps to show people that the way to check the headlines is to dig down a little bit deeper, and then helping to develop and promote those types of skills and ways to access that information.
Dónal, isn't that a sort of fairly academic perspective? Because, I mean, obviously it's the misinformation with malign content and the disinformation that is really the problem that we face. And to what extent can we identify these sources? I mean, it's an interesting observation is from Twitter is that stuff that is misinformation, that is that is retweeted maybe billions of times comes from 12 accounts. So essentially what you see is that there are people who are definitely misinformers. So how can we deal with this particular type of question? I mean, what can people do in order to try to work out what is the best source? So Sam and then Donald.
This might be slightly provocative, but one thing I've been doing when people ask me this is to tell them the story. When, 35 years ago, I was a student in Trinity and really enjoyed it and learned a lot. But on the inside of the back doors of the toilet cubicles in the men's block and the arts block, I was never in the women's, so I can't comment on that. There were lots of statements and graphics, all of which were inappropriate, many of which were humorous and mostly entertaining. And about every month, Trinity would paint them off and then they would emerge again. And I think we have to teach the next generation that Twitter and Facebook are largely like this, that it's entertainment and it's personalized. Most of it's inappropriate, it's transient, and anybody can literally write anything there. So because something's written on the back of the toilet door in the arts block in Trinity College Dublin doesn't give it any authority whatsoever, and we should treat BitChute and Twitter in exactly the same way, because any of us can write anything there and we can write exactly the opposite with no editorial review. So we need to really counter that idea that what's written on the internet is intrinsically true. Lots of people seem to believe that for some reason. I have no understanding of why they believe that.
Okay.
Yeah, I agree completely with Sam, and I think it's a reflection of where we are, that the idea of checking your sources is perceived as an academic pursuit that somebody in the ivory tower is up to. But I think if you go back to the basics of even trying to figure out how to farm, how to bake something. You don't just like read it on the back of the toilet. You have your trustworthy sources that you use for that, and it's trying to bring that the value of checking things into everyday life again, so that we don't think that Twitter is where I'll find out how to bake a great cake, when that's reality. You never know what you're going to be reading about there, but that in all areas you've got to check your sources, see who's writing those things. And as I think Maria was pointing out, that the personal role is really key as well. Having doctors and nurses that people know and trust, and that they are involved in helping people to understand the details or the numbers or whatever element, that's really building up that trust within the community as a whole is, I think, the key. And it's not going to happen with the flip of a switch. It is going to take a while to really get involved with that in all sorts of levels.
Nick?
Thanks, Bert. Just if I might, before I make my point, Sam, I'm sure that the etchings on the back of the Trinity toilet doors are held in with greater trust than those in the back of the UCD toilet doors. Sorry. But I suppose to come back into, I think that the conversation is very much based around trust of academic information, and we're approaching it from an academic point of view. The majority of the patients I meet won't go to academic journals, won't read literature, and they won't, to a large degree, spend half an hour or an hour, reading a complicated article. So we do need a way of ensuring that the information that our citizens and our patients receive is trustworthy, and that information is, they're going to consume that information. I would disagree slightly with Dónal about, how you learn to bake a cake. Well, I learned to fillet a fish on YouTube, and I didn't go to too many sites before I filleted the fish. I looked at one or two videos and then I filleted the fish. So I think that we have to accept that there is a method of disseminating information, and what we need is a way of ensuring that important information is in some way policed. So whether that is that we have, an ethics watchdog that rules over social and print media and audio-visual media, that there has to be some way that we try and guardian that in a way that we can communicate with people in a responsible way while still preserving the right to free speech. And if I might just tell an anecdote from my world, which is non-vaccine related, but again related to a broadsheet, very trusted print media. So I have a slight interest in asthma, and very briefly, there are two types of inhalers. One inhaler keeps you healthy, so it's called a preventer, and one inhaler, when you become unwell, it rescues you. It's called a reliever. So the relieving inhalers are blue, and if you're using a lot of your blue inhalers, it probably means that you need more of your brown inhalers. But there was an article printed, or there was a scientific article that identified the fact that people who don't use enough preventer inhaler use more blue inhaler. And then the article concluded that people whose asthma was uncontrolled were more likely to end up in hospital and more likely to end up with asthma-related deaths. The broadsheet, the Irish broadsheet, ran a big 2-inch headline, "Blue inhalers linked with death," which of course is entirely the wrong message, but it results in lots of parents not trusting the blue inhalers, not wanting to use them. And this was from a trustworthy source, you know, and very often people only read the headline, or they lose interest a couple of paragraphs in, and they don't get the details. So it is a significant problem. I don't have a solution, but I think we have to recognize that while academic literature is important, that the people that we're communicating with have no interest whatsoever in reading academic journals.
Yeah, thanks. Simon, I think.
Yeah, but one of the things I think we have to bear in mind is the quality of our own engagement with arguments that we perceive to be false. Because in fact, and I don't know how many of us have engaged recently with people who take a view that we'll use the portmanteau word, a contrarian view about COVID vaccine. But when engaging with people, as I've done on a couple of occasions recently, it is important to note that a lot of the arguments that are put forward contain a portfolio that consists of some true positions from which curious things are reasoned, some half-true positions, sometimes half-true deliberately, sometimes half-true because they're poorly understood, and sometimes only a small number of untruths. So it is important to remember that just because somebody's position is a position from which you violently dissent because you accept the orthodox view of how one might reasonably respond to COVID, it is important to recall that merely because somebody disagrees with you, that only some of their arguments may be untrue. And it's important to bear in mind at every turn the obligation to have a real quality engagement with those elements of what is often a portfolio position that are in fact at their core in some way true or in some way arguable.
I think you're absolutely right, and I think it is that, you know, that engagement with people who are hesitant rather than completely misinformed, I think is something that we'll come back to in some of the later questions. So it is undoubtedly the case that engagement needs to be on the basis of a respect for people's opinions in the first place, and then to see to what extent we can engender a change in that. And certainly when you're looking at the sort of experience that people have, and that's quite possible, but it is very time consuming and very requires a great deal of effort. Kingston, did you want to?
Yeah, I mean, I think the public has a huge appetite for the understanding of the science behind a lot of what's happening right now with COVID and COVID vaccines. That's my impression of it. And I think there are two groups of people that really can help with this. One are the journalists, and more probably actually the editors that write the headlines, because very often the articles don't necessarily reflect what's in the headlines. Because the headlines are designed to be sensational and to attract readers, but unfortunately everybody doesn't read the article underneath the headline. And the second is actually with the medical profession, and sorry Sam and Nick, I'm not having a go at you, but really there's an onus on a change in the way that the medical profession deal with the public. In the past in Ireland, most people didn't want to know about their condition when they went to the doctor. They had 100% trust the doctor was going to sort it out for them, and they didn't actually want to know what was wrong with them even. And this is still the case with the older population in Ireland. I'm sure you'll testify to that, Sam and Nick, that they don't want to know what the disease is. But that has changed dramatically, and is changing, I assume, a lot now with COVID. Everybody wants to know what's behind this disease. We're talking about COVID, and they want to know about the vaccines. They want to know how they work. They want to know which one is best. They want to know what the side effects are. They want to know what the benefits. So I think, you know, okay, you don't have time to go through this with every patient that you see, but I think it's very important that the medical profession, open up a little bit more to the public.
I think maybe this is a good segue into our third question, which is distrust in established science and medicine on the rise, and what are the threats and the causes? So I don't know who wishes to start. Sam, do you want to start on that?
Yeah, I'm happy to start. I feel that taking a long view, it certainly is on the rise. 500 years ago, this would have been all as seen as some sort of visitation of evil spirits or some guilty communal or individual behavior that we'd done, that our guilt would lead us to believe that this was punishment. And, we've moved on a long way from there. And now we not only see, conceptual models that help us to understand why things have happened, which is a good start, but we're also starting to see powerful tools to fix them. Number one, social distancing, and number two, now vaccines. And I'm hoping there'll be number three, small molecules in a few years' time. So we're actually seeing those things, and you don't have to be sort of wonderfully smart to sort of see what I've just described. So I feel that there's very high levels of public interest in science. I think I agree with what Kingston said, that the medical profession needs to be much more open. I think that started to happen probably 15 to 20 years ago. And many of us, I look after hundreds and hundreds of people with HIV infection, and there are really good websites, one called HIV Insight and one called the Terence Higgins Trust, run by people with HIV, one in San Francisco, one in London, that we tell our patients about and say, you've got to learn about this, learn HIV 101, spend 6 months learning about it. The more you know about your disease, the better you'll be able to look after yourself, and we can partner better with you if you're well informed. And this is equally true for COVID. In medicine, we have a very strong respect for a principle of autonomy, not just beneficence doing our best for somebody else, helping the other person on their terms, but autonomy, meaning that our patients have a sense of who they are that's different from our sense of who we are or our sense of who they are, and that we must respect that autonomy. And that's not just in Irish biomedical ethics, quite an international principle, has sort of 15, 20 years, this medical principle of autonomy, which I suspect Maria could talk more wisely about than I do. But that involves respecting the other person, our patient or our communities that we're advising to have the freedom to make their own choices, even if we disagree with those. So I think that's a really important, useful tool in all this debate as well.
Maria, do you want to come in on this?
But before saying something about this particular issue, I want to go back to the previous question about trustworthy source of information. I'm afraid it's wishful thinking to imagine that people are not going to rely on Twitter or Facebook or social media for as news sources. In fact, my own project, the project that I'm running, Peritia, which has various elements, including an investigation of social media impact on trusted experts, shows that younger people in particular are focusing on social media as the source of news and information. But there are ways of trying to counteract the biggest danger to spread of distrust, and that is the spread of disinformation and misinformation. Disinformation is willful spread of misinformation, but often misinformation is just spread through a click. So various organizations, NGOs, academics, news sites are developing methods of countering and fact-checking disinformation, and that's what we need to push all of of us in order to create what in our project we call a climate of trust that includes the experts. And actually it's quite easy to distinguish between trustworthy experts and the ones who are not trustworthy. That's not a big problem. But also beyond that, what are the sources that reflect correctly the views of these experts? And that's the more difficult and more complicated issue. But even that's not beyond hope. And once we start engaging with people at that basic level of even game playing, there are online games where younger people are taught to distinguish between fake and fact. And at that level, then we can indeed address the issue of fake news or misinformation, even when it's becoming very pernicious and showing itself in terms of conspiracy theories, etc. But I can come back to this point later, maybe.
Okay. So anyone else who wishes to contribute here? I think it is, I think it is clear that we've seen a tremendous amount of emphasis, certainly from the politicians, on following the science, of whatever the science is, in the sense that, in my opinion, there are always 3 or 4 different sciences, and they are all speaking in different directions and having different jargon. And to an extent, like the virologists want to cut down everything and just say we all go home and sit there and wait until it's over. And obviously there are others who say, no, we can't do this. And so it's an interesting sort of experience that we've had. But I think what is probably more interesting for us to discuss today is to what extent how can we engage with vaccine hesitancy? Because it is, as Simon already indicated, it's not something that is just based on a complete set of misinformation. So there are questions to be asked, and in that sense, it is important to say how do we deal with that particular issue? Because I think we will be confronted with this. Over the next few months in several ways. I mean, Kingston has already raised this question of the blood clotting complications with some of the vaccines that are based on the platform of adenovirus vectors. And to an extent, you can see that particular question will be, in my mind, be probably augmented by other questions that will rise when we have 100 million doses used. That's unavoidable. So, Simon, do you want to come in first? Yes.
One of the really interesting things is something that Sam touched on a few minutes ago, which is the fact that there are different ways of viewing healthcare and its purpose. And a lot of the last 20 or 30 or 40 years have been rooted in a philosophy that it's about patients having more information, it's about patients understanding more about their own healthcare, and about carving out a sphere of enormous respect for patients' autonomy. And the courts, in interpreting autonomy, have reflected, for example, that people are entitled to refuse medical treatments or medical interventions for good reasons, for bad reasons, for no reason at all, so long as in doing so that they are of sound mind at the time of making the decision and have relevant information for making the decision. And then all of a sudden, along comes a public health pandemic that upends all of these notions of the primacy of autonomy and says, actually, I know we said all of that stuff about autonomy, but honestly, we have to get you all vaccinated. And all of a sudden you have bumping up against each other a society that has increasingly valued autonomy in the sense of when engaging with the healthcare system, and a healthcare system that says, yes, autonomy is really important, and you're allowed to have crazy ideas and crazy reasons for refusing treatment, but we'd like you to park them for the next 6 to 9 months. And that creates a very interesting tension. So one of the things about overcoming vaccination hesitancy is of course about information, but it is also about saying, yes, all of that stuff that we said about autonomy before, could you just press pause for a while? And that creates a really interesting tension in the field of medical ethics. It always seems to me pandemics really test a lot of the models that we have adopted as being the way in which we should interpret or do interpret bioethics in the Western setting.
Yes, I think you raise a very important point, and of course it is, you know, like I think you could put this into a much wider perspective and say that it's clear that even in one of the most freedom-loving countries like the US, the Supreme Court in 1904 already agreed that compulsory vaccination could be something that would be necessary in order to deal with a public emergency. And, you know, this is a virus which luckily is relatively, has a relative low mortality rate if you compare it, say, to Ebola virus, where we might be in 30% or in that sort of level. And then you enter into completely different discussion, of course. And to an extent, that's an interesting point, is to how far do we under this set of conditions accept the limitations on our freedom? So Dónal and Maria have their hands up. Dónal first and then Maria.
Yeah, thanks. I think this is a really important part of all of this that Simon raises. And I think part of what the kind of relatively new field of disaster ethics has been pointing out is that a Western view has really emphasized autonomy to a way that most of the rest of the world has not done. And that many ethical situations and dilemmas, or I would think possibly even all of them, they're actually about balancing various ethical principles, but that for various reasons, autonomy has come to be seen as the trump principle. I mean, the trump card in terms of ethics in a Western medical setting, and that we're actually getting closer to something that is, I think, more realistic. It's the messy world of trying to make ethical decisions when different principles have to be balanced, and that we really need to emphasize that, like Simon said, when you meet someone who is vaccine hesitant. And I would just say that from an ethical perspective, that to engage with people who are hesitant, that the first step should always be to listen, to ask, you know, what's leading you to have the position? What are the fears you're coming at? What would you like to know, you know, about the whole situation? And in that way, that the perspective that sometimes science and medicine can have of coming in with the answers needs to be kind of turned over, and instead come in with questions and an openness to listening to where people are coming from.
Okay, Maria, you want to follow up on that?
Yeah, the point I was going to make was very much in line with what Dónal just expressed. Well, I would like to add that even from Western ethical position point of view, autonomy is a rather recent development. It's only post-Kantian philosophy that emphasizes autonomy. If you go back a bit further in terms of history of philosophy, the Aristotelian and Neo-Aristotelian views have emphasized communitarian values and the values of well-being in general. And if you wanted a ranking of goods, I think the principle of not doing harm and not being harmed is much more important than principle of autonomy. And here in the conditions of the pandemic, I see so blatantly people using the principle of autonomy to argue for freedom not to wear masks in Ireland, even let alone in the United States, or to congregate, etc. But the harm done to others always should come into consideration when you're talking about ethics. It's not just the harm done to us as a person in terms of our freedoms, but the harm that we do to others by taking away their freedoms, by inflicting an illness on them, by transmitting a virus. So it's really, there's no ethical question there of a deep sort to deal with. If we want to rank values, we should rank not doing harm higher than autonomy, and that should apply not just now during the pandemic, but at other periods when we are looking at medical ethics.
Simon, you had your hand up, or did Maria cover your point already?
Yeah, well, just to say that this, I suppose, in a sense, for anybody who's interested in what Maria was going to say, because I think it's worth pointing out that autonomy doesn't mean the same thing to everybody. And for some people use autonomy in that lazy sense that Maria just described of it's my freedom to do whatever the hell I want. And properly understood, autonomy could perhaps more reasonably be described as the freedom to do with whatever you want within the set of rules that we must all agree to abide by as a society, within the limits of what Rawls might have described as reasonable pluralism, or what Honora O'Neill describes as a reasoned autonomy, not sheer mere autonomy, I'll do whatever I want, but autonomy properly construed within a society. I saw somebody sent in a question a little while ago, well, doesn't pausing autonomy mean rolling back the social contract? And of course, no, it doesn't. It means properly interrogating what autonomy means and recognizing that in all spheres of life, autonomy is not without its limits.
Sam?
I was going to, well, this discussion about autonomy, which I guess I sort of introduced, really reminds me, early one morning being interviewed by Pat Kenny with somebody who had a very strong liberalism approach to life, saying life, liberty and freedoms is what it's about, and couldn't understand why we couldn't walk more than 5 kilometers, and felt this was an inappropriate restriction of freedom. Pat Kenny, the interviewer on News Talk, then went for the fellow and said, well, the reason is because your freedom to walk more than 5 kilometers is impinging on somebody else's right to life, which is a very concrete example of what Simon's talking about, is when there's a balance of these. So it's not this idea that autonomy means you can just do everything is kind of a false illusion in some people's mind who've got sort of fixated on this idea that just doesn't work in a communal society. What I was going to introduce was another, obviously there are 4 sort of principles of medical ethics that seem to work across cultures fairly well. We're teaching in Bahrain and Malaysia and Dublin and lots of international students. And the other one is what you could call fairness, equity or justice. And I feel it's important in this discussion about COVID-19 to put that out there. And because my view is that it's the unfairness and divisiveness and sort of how COVID-19 essentially affects and kills more people who are poor and dispossessed. That is one of the features of this pandemic that makes it more difficult. And our social cohesion is fine if you're wealthy and comfortable and live in a nice house with 3 people and 4 bedrooms. But if you are squashed 6 people to a bedroom, and there's a housing crisis in Ireland, has been for several years, and there are lots of people in terrible little grotty houses where they're paying €1,000 a month to be in a smelly little room full of growing fungus. And so this idea of trying to say, the society, the government, the stable community, you owe some loyalty to it, where it's treating you so badly and you don't even have a decent place to live, or maybe a job or an education, and no stake in it, no ownership in it, is really difficult. So my view is we have to include this idea of justice and fairness and social justice right in the middle of this discussion about response to a pandemic. And in fairness, I've been saying that for sort of a year and a half. It often gets left out and obviously gets sometimes very politicized, but in my view, it's the necessity for all political parties to achieve some perception of fairness and some real fairness to get over the pandemic. And that is, of course, the medical principle of fairness and justice, which I think is a need to counter vaccine hesitancy by having more justice and fairness in our distribution of resources in Ireland.
Well said. Dónal?
Yeah, thanks, Sam, for bringing that in, because this is something that Nick touched on, and I really wanted to bring up today, because you concluded with justice and fairness in Ireland, but and I know that you would advocate that this needs to be seen much more broadly as well around the whole globe. And in terms of the potential for harm that exists at the moment, if we in the rich countries are going to keep all of the vaccine to ourselves and take care of ourselves first, and leave the less wealthy countries to catch up in a couple of years' time, there is going to be massive harm, and it's going to be, you know, short-circuiting any sort of recovery we might want. And this is where I think, you know, some of our debate and discussions is very much focused on those of us that already have an awful lot. You know, some of the wealthiest countries already have 3 and 4 times the numbers of vaccines they need purchased or ordered, which is making it impossible for the World Health Organization through COVAX and the poorer countries to even start their programs in some cases. And so I think this is part of the discussion that we need to have about bringing these much broader ethical principles into a global context, and not leaving it at just our local kind of first world concerns.
Yeah, I think certainly the sort of the failure so far of the whole COVAX scheme is really an indictment of this sort of position that people take. But it's also, you know, it's easy for us to sit here and, you know, it's the sort of guilt that we can talk to and a guilt feeling that we can develop. But at the same time, it's you know, like it's an extremely difficult political thing to say. Let's not look after our own citizens first, and then we'll start doing things. You know, I'm fully with you in terms of the objective that you explained. But as a political question, it is a real difficult one. And one of the things that we've of course have seen is how difficult it has been for the politicians to deal with this whole question. And Maria, you have your hand up.
Yes, just to add to this particular discussion, that maybe we could emphasize that by looking after other countries, we are also looking after ourselves. We are an interconnected world. The biggest danger right now is coming from variants of the initial virus, and coming from countries such as South Africa or other countries where there isn't great deal of vaccination. So rather than emphasizing the moral argument that given the sort of nationalism that has started prevailing in Europe and America, maybe we can appeal to the self-interest of people and not just their moral sense, because it is absolutely true that if not everyone is vaccinated, then no one is vaccinated, given that the virus can generate new variants.
Yeah, well, that's still an open scientific question that I think we don't want to go into today to see to what extent that particular scenario is or is not reasonable. But Nick, can I come to you to say, you obviously must be confronted with vaccine hesitancy in your practice. How do you deal with that on a personal basis with your patients?
Yeah, I suppose as an issue, it's got the societal response, which could be educational and from schools and public health, but certainly on an individual patient interaction, we talk about the pros and cons of treatments all the time, including vaccines. Vaccines tend to be particularly emotive reasons for people considering and pausing with regard to treatment. But really, we approach it like we would approach any negotiation. Like, you try to understand the other person's point of view. And thankfully for 75% of people, when it comes to vaccines of all sorts, right, that they're going to have the vaccine, whether it's a flu vaccine, whether it's a childhood vaccine, you know. And I think on probably on a population scale, that might be what we see with the COVID vaccine as well. However, interestingly, my own practice has just this week finished completing the first dose for our over 70-year-old patients, and we have I suppose a vaccine compliance rate or an acceptance rate of nearly 99%. Very, very few people over 70 in our practice, and we're at nearly 1,000 patients with vaccines administered have refused the vaccine. And there's been very little, most people have been very, very happy to get the vaccine in that age group, and there's been very little vaccine hesitancy. But I think as we move down the age groups, we're going to see that change, okay? And we're going to see it's going to become more what we see with the normal vaccines. And we'll probably see maybe 10% of people who will be it'll be an absolute no. You know, we're not going to have the vaccine, and then we'll probably be left with 20 or 25% of people who we have to negotiate with them about the benefits of them getting the vaccine. And like any negotiation, you can have a couple of outcomes, right? You can have win-win, where they see your point of view, they understand the science, they trust you, and like the MRBI polls year after year tell us that pharmacists and doctors are very well trusted among society, so we're well positioned to roll out these vaccines. So you might get the win-win, but what you might also get the win-lose, right? So what you don't want is somebody accepting a treatment that they didn't want, right? That's not good. But equally, if the person goes away happy that they've refused it, that's not necessarily good either. But the last thing that we want in that negotiation is lose-lose, where the relationship gets broken because they haven't had the vaccine, because this is one episode of care, and we look after them for the whole of their life, for all of their illnesses. And what we want to do is we want to keep the relationship open, and we have to, in the end of the day, having made our best efforts, if they haven't accepted that the vaccine is a treatment that they're going to receive, we have to accept that and accept it in a way that means that we're still the safe place for them to come for future care. So I think that's important. But when it comes to how you go about the negotiation, I think having spoken a lot about the science and the importance of the science, and certainly that's where you can start talking to people. But I think a lot of people respond more positively to stories, you know, to listening to a story. So it might be the story, like we have a lady that came in this week, and her husband passed away from COVID-related complications in January, and she got her vaccine, and she was crying, and she was crying from a mixture of joy and sadness. So she was delighted, she was really relieved herself, she got the vaccine, and she was incredibly sad that her husband had missed the opportunity to get the vaccine. If the vaccine had been available in December, maybe he wouldn't have died from COVID-related complications. So that's one type of story that might win an argument with somebody. Another thing we have to be careful about when we're talking to patients in relation to vaccines is the language that we use. So we very often, unbeknownst to ourselves, use scientific language. So the word herd, what does that mean to people, right? So I'll tell you a story that this comes from a patient who taught me a lesson, I'd say 20 years ago. So I was trying to explain that this guy, he was probably in his 60s, and he should really take the flu vaccine. This would be good for you. He said, well, what would the benefit be, Nick? And I said, well, he said, I never get the flu. I mean, I'm never sick. And I said, well, you know, if enough people get it, you know, we'll have herd immunity. And he says, what does that mean? So I said, I tried to explain what herd immunity was, and I hope I succeeded. But he said that to me. He said, Nick, I don't care about the herd. I care about myself. So from that day on, I've never used the word herd. And what I say to the patients is, we want to get community immunity. So we want that people in the community don't get sick. Because what's a herd? A herd is, for most people, it refers to animals, right? So I think we have to be very careful with the language that we use. And while the science and the facts are important, I think that stories tell people more, and people remember more about stories and make decisions on the basis of stories. As long as the stories are based on, I suppose, facts and science, and are moving people towards making what we feel is the best decision for them. So that's what I think. I think as well, the last thing I say is that I think we have to be careful that in the arguments that we make and the statements that we make to people. So it's very easy to get a patient's back up, right? So if you say to somebody, you know, you really should get the vaccine because it will mean that there'll be less old people or less people, elderly people, who will get sick and end up in ICU and will die. And then, but that person could very easily say to you, yeah, are you saying that because I don't get the vaccine, I want elderly people to get sick and go to ICU and die, which clearly nobody wants. Whether they want the vaccine or they don't have the vaccine, they don't want that. So those type of arguments where the opposite statement to the statement that you make doesn't really hold true, because nobody's going to do something or not do something with the intention of causing other people to become unwell. They can very easily fall out of bed at the patient, and you're actually losing the argument rather than winning it. So that would be my...
Okay, thanks. Now, I think we all must recognize that we are a storytelling animal. Can I just move on to the last question, and that is, should vaccines be mandatory or voluntary? Now, most of you have already indicated that you're not in favor of mandatory vaccination, but let's assume that we would have been confronted with a virus with a 30% death rate. Would you then still hold to that opinion? So who wants to go first in this particular one? Kingston.
Yeah, I mean, I think it's a very valid point, Bert. If the disease is going to kill 30% of people, I don't think there will be hesitancy, quite frankly. If there was a vaccine that prevented it, everyone would be killing to get it. So I think the public can weigh up those risks themselves. But to me, it's all about enabling rather than mandatory. So enable people to do activities that they otherwise wouldn't be able to do if they get vaccinated. So it has to be a carrot as well as stick approach to this if we're going to get high vaccine coverage, especially amongst the young population, where, as somebody's pointed out, the biggest issue is going to be. And the other issue is around mixed messaging. We've had endless changes in plans and politicians giving pronouncements about the numbers of people who are going to be vaccinated by a certain date. And they all should just stop doing this, because it's having to be changed practically every second day. And the consequence is that the public are fed up with listening to what they're going to be promised, and then that changes. So that's been having a huge negative impact, in my view, on the vaccine, the confidence in the vaccination program. So I do believe that openness and not mixed messages and not, I know we've had to change direction because of issues we would never have predicted that were going to happen, such as the clotting issues, and that's understandable. And the supply issues were other issues that they couldn't, well, they maybe could have predicted some of them. But I do think there needs to be very clear, unambiguous, honest answers given to the public about every aspect of the vaccine, whether it be the supply, the side effect, or the benefit.
Thank you. So in terms of dealing with this, like we are obviously not confronting a situation that we are looking at a virus with a very high mortality. It's low, so we can afford not to go for mandatory sort of vaccination. But what does the panel think about, say, the introduction of the requirement of some form of an immunity passport to indicate whether you can participate in particular functions in society? Maria?
So maybe the rest of the panel does not agree with me, but I think some form of mandatory vaccination for travel will be in order. After all, if you travel to certain countries, non-Western countries, there is mandatory vaccination before getting a visa. And now having mandatory vaccination traveling in Europe and in richer countries, it sort of evens things up a bit. So why make an exception in this case when we do have to vaccinate if we go to Southeast Asia or Africa or similar countries?
That comes back to my point about the facilitating. I mean, one way of facilitating people to, encouraging, let's put it that way, people to get vaccinated is to have the vaccine certificates. I don't like the word passport. And, some countries are already doing this, like Denmark and Sweden, Israel, others. Australia and New Zealand are doing it. They have a travel bubble, and I think it's a really good way of encouraging. When it comes to the sort of last cohort, when we have the last 20% of the population to get vaccinated, I think it's really good. It would be a really good incentive for people. And going to sporting events is the other thing. I mean, what would I give right now to be able to go to a rugby match or another sporting event? I think a lot of people are in the same boat. They would really love to, and going to the theatre, going anywhere. If you can do that and have a vaccine certificate, I'm all in favour of it.
Let's call it an immunity passport certificate, because I think we don't need to get immune by we can do it by passive immunization with cocktails of monoclonals, or we can do it by getting.
I agree, and I think that previous infection. This is more controversial. I think previous infection should also be on that, as some countries have done. And I agree with you, Bert, that immunity certificate is a term I would use. Yeah.
Simon first, and then Sam. Simon, you're use it.
You would think that a year and a bit into the pandemic, I would know how to unmute myself. I'm sorry. I think there is a world of difference between, on the one hand, actually mandatory vaccination, and on the other hand, incentivized vaccination, or vaccination that may be required for things you elect to do. So there are two, I think, very different scenarios from the idea of mandatory vaccination. And I think we are unanimous in saying that in the face of COVID, the arguments for mandatory vaccination are very thin indeed. That's not to say that there may not be certain subsets of the population for whom a cogent argument can be made that in order for them to fulfill our role in society, that they should all be vaccinated. But that runs counter to the idea that if all of us generally are vaccinated sufficiently, it won't be necessary for people to do those who do those jobs to be vaccinated. So I think it would have to be a very well thought through argument, and I think probably only a last resort. But I think the only people in respect of whom a cogent argument can be made are those people who, because of the role they fulfill in society, it is essential that they could be vaccinated. But I haven't heard that cogent argument being made yet.
Yeah. Sam, did you want to come in?
Yeah, I'm sorry, I moved my location, apologies. All the things going on in my shared space. So I was going to say that, to me, from the sort of technical knowledge point of view, I don't feel we have enough technical knowledge about how well vaccination 4 or 6 months ago with all the different vaccines, or even with natural infection, how well that protects you. So we don't know the duration of immunity after 1 dose or 2 doses very well. And until we have some confidence around those numbers, then it's hard to make sense of a vaccine passport, in my view.
Okay. So we now have a session of questions from the public, and I am looking through the chat and I don't see any particular so one of the questions that I see here is how do we, the vaccine is of course already highly politicized in Europe and doesn't engender trust, and Ireland turned down an offer of Russian vaccine. Begs the question, is it about health or politics when other EU countries and Hungary use it? I mean, how far do we go? I mean, I looked at the, of course, I looked at the composition of the Sputnik vaccine, and you would expect that if there are blood clotting problems with the J&J and with AstraZeneca, then they should be there with the Sputnik vaccine as well. But so we have turned this down. So how far do we go in this sort of question of the vaccine nationalism? It's a worrying one. Sam.
Could I come in there? I mean, I think that I had 2 initial issues, if you like, with Sputnik 5. One was that it was licensed and sold and promoted in Russia when there was very, very little safety data. They only had a phase 2 trial of 500 people and they put it on the market. And that's not how we do things, and it's not how we want to do things, and it's not a good way to do things. So that's the first one. The second problem is that now the Sputnik 5, it's a bit like us calling an Irish vaccine Shamrock 3 or something like that. So it's intrinsically nationalism bound into the name, and that was how the promoters sold it. So they have published, obviously, in the Lancet in December, safety data on about 20,000 people. The question is, have they submitted detailed results of a phase 3 trial to the EMA or to the Irish regulator to show that there's reasonable safety, not just on things like clots, but even its production capacity? Is there E. coli growing in the production line, for example, or are the processes for checking for lipopolysaccharide or whatever other contaminants in the final product adequate? And that's really a technical question that can only be answered by the regulators in Europe, EMA, or in Ireland if they decide to go for Ireland. So I don't think it's been rejected as such. It's just our regulators have not yet seen the adequate dossier, which is very well laid out dealt with International Commission for Harmonization for the last 15 or 20 years, there are very clear rules on what sort of safety data you need to get, you know, vaccination, whether emergency or not. And that may come. I'm reasonably optimistic that at some stage we will have a, you know, not just a Sputnik 5, but 2 or 3 Chinese-made vaccines, Sinovac, Sinopharm, and maybe a couple of made Indian vaccines, as well as Novavax and J&J vaccine working here. And I think that will solve the vaccine problem when we've 12 competing companies selling into not just Ireland, but the whole world. So this is going to be a market with 15 or so players, hopefully in a few months.
Sure. So there's another question from the public, so which asks Maria to comment on how we persuade the public that global vaccination rather than national self-interest is the best way forward.
Well, I think I did say something about that, but maybe I should expand on it a bit more, in that just now I'm not very hopeful that moral arguments would succeed, because we are going through a phase of thinking in terms of national interest. So I would like to emphasize the general good of that will come from having all countries vaccinated, at least to a reasonable level of community immunity, so that travel becomes possible and the normal flow of goods and people, etc., is resumed, because we are an interconnected world. We cannot just stay in our little islands and keep away from the rest of the world. And we don't want to do that. We want to go on our holidays, etc., and communicate with the world. So I would appeal to our own self-interest just now, even though as a philosopher, I would much prefer to appeal to more lofty moral values.
Yeah, so there's a question, is it at this moment even ethical for a person in Ireland to accept the vaccine when essentially healthcare workers in the rest of the world are not vaccinated? It's a difficult one.
It's just that if we don't accept the vaccine, it won't go to the healthcare worker in the third world country. It's a bit like the arguments we used to hear as children that think of the starving children in Africa. If you don't eat your food, what about them? Well, that food would not have gone to those kids. But we should put pressure on our government, whether out of self-interest or out of moral values, to make sure that there is a flow of vaccine and we don't sit on our hoards of vaccine and not share them.
So I sort of have another question, which I think is interesting to me as a person, as a scientist and academic, is the following: that what we have seen, of course, during this whole pandemic is that medical and biological scientists who used to be somewhat averse to preprints launching on preprint sites have become used to doing this. It's a situation where obviously it has had benefits in the sense that it does lead to a very quick dissemination of information, some of it of sometimes somewhat dubious quality. And it's an interesting question in my mind in relation to the trust in science question that we discussed earlier. It's like, how do people feel about that particular practice, which essentially has helped communication, but at the same time has an inherited set of problems with it that may well come to bite us in the longer term. Kingston, you had your hand up.
Yeah, I mean, I think there's some merit in these, because they get out information that's very useful for other groups to start working on the basis of the information they've got. It's like a sequence or a method for doing something, or some data that tells you the direction you should change your research in. So from that point of view, it's helping the global effort in a particular research area. I think the downside of it is, because it's not peer reviewed, that some of the data is of dubious quality, and then the conclusions are based on dubious data. And then the trouble is that you get journalists actually duplicating the headlines from the authors that have not been toned down by reviewers. I mean, most of us as authors of paper will be very well aware when we send our papers for peer review, in good journals in particular, the editors and the reviewers will make you tone down some of your claims, because mostly the claims you make are not always substantiated by the data. That's not the case with a bioarchive. You can say what you like effectively. But so when it goes to peer review, you'll find there's a big difference between the major conclusions, and sometimes at least, and what's in a bioarchive paper. So there is a little danger with this, in that, you know, when it gets into the wrong hands, they interpret it in the way that mightn't be reflecting of the data, or the data mightn't be analysed in as strenuous a way as it would in a real world. But in balance, I actually think it's been a benefit in COVID-19, because it's got a lot of information out there very quickly that otherwise wouldn't have been published.
Yeah, I think it's an interesting sort of experiment almost. I think in particular the problem that one obviously sees is that indeed the media start reading this stuff, and essentially are not often in a position to evaluate what the truth of the message is. And this is, I think it is an interesting sort of a lesson that we've learned. And coming back to the whole question of what is trustworthy and what is not trustworthy, here are scientists who are putting stuff on, and it is almost impossible, in my opinion, for journalists to work out what the real value of some of the messages are. Nick, you wanted to come in, and then Dónal and Sam.
So I would absolutely defer to the other panelists on the following, which is my own opinion, and that's that the question about trustworthy science goes beyond the research into COVID vaccines and what we've learned about COVID as a disease over the last 18 months. What I see as a practicing GP is that randomized controlled trials have in some way become the Trojan horse of the pharmaceutical industry, and that is leading, I think, to mistrust among healthcare professionals, but also among the public. So we get randomized controlled trials that don't reflect real world situations. We get participants, both patients and clinicians, that don't reflect real world patients or real world clinicians, because they, for whatever reason, like the patients are emotionally involved in the illness. The patients generally are more committed to the treatment, I would say, to get involved in a trial for whatever reason than patients in the community. The patients that are accepted into randomized controlled trials are often perfect patients for the trial. Multimorbidity is not represented. So you take diabetes as a good example. Diabetes is your quintessential multimorbid illness, and yet trials of diabetic drugs frequently exclude diabetic patients with kidney disease, with heart disease, very common conditions within diabetic patients. And we've seen an example over the last 10 and 15 years of drugs that have got to market but have subsequently had cardiac side effects and been withdrawn. So I think that, and again, I'm an end user and I'm not a producer of the science, but as an end user of the science, I think that that we need to be careful about how we're generating, and sorry, Dónal might have strong opinions on this, but about how we're generating science, and who's paying for it and what are the outcomes. I see lots of pharmaceutical companies marketing their medications on the basis of surrogate endpoints. So you take drugs that are maybe designed to treat diabetes, and they market the drug as being better than another drug because of maybe an effect on kidney disease. So we really need, I think, to take a stand back from randomized controlled trials, the funding and the way the information is produced, and see that certainly they clearly have an awful lot of merit. They've taken us away from the snake oil of medicine, but I feel that they've been hijacked to a high degree by the pharmaceutical industry.
Thank you. Dónal?
Yeah, I just to kind of pick up on the preprint aspect and more generally, I think there's, to me, a lot of these keep coming back to the importance of balance and understanding the challenge, but the need to balance various principles. And so you've got, with the preprints, you've got the urgency and the rush to get information out as quickly as possible, but you have to balance that against the reliability. And people who are using that need to be aware of those, including the media and practitioners, and seeing that this has a legitimate role But for example, a number of South American countries based their national policies on some preprints, some of which turned out not only to be inaccurate, but to be fraudulent. And that's had massive impact. And so, again, the users of the information need to be really clear about what it is and use it appropriately with a certain degree of caution so that it doesn't have overly negative effects.
Maria, did you want to come in there?
Yes. I think preprints, based on the studies that our project has done, have had, as you have mentioned, both positive and negative effects. But there's a further problem behind all of this, and this goes beyond the COVID issue. The fact that scientists disagree, and that disagreement is expressed by the media or through the media views, that is a factor in establishing distrust in science and undermining trust in science. There's enough data for that point out there for me to be able to say this with some certainty. But that really is a misunderstanding of science, if I may say so, in the presence of the scientists here. Science is a fallibilist enterprise. It's not a question of certainties. Scientists both verify and also accept falsification of their theories. That's how science has progressed. But this is the point that has to be conveyed by the science communicators to the general public, that the fact that scientists disagree with each other actually is a reason to trust them, because science is self-correcting in ways that many other positions, many other sources of knowledge in the world are not. And that applies to this open way of publishing, which is more risky as well as the peer-reviewed one, because even in peer-reviewed publications, you do get differing positions in on any given scientific view, and then you choose based on factors that are available. But all those choices are temporary, because you accept that there's no certainty in science. The next theory would be hopefully better than the current one.
Yeah. Trust science, but not the scientists. And to an extent, you are into that particular situation where I think this is something that I've found myself, is that to an extent you see that journalists start to seek out scientists who will almost support their view on the first instance, and that is a very dangerous sort of direction. Sam, do you have any comments on that?
Yeah, I was going to talk about the preprints and the ending up in the media, and maybe suggest that maybe even RIA, for example, as an institution can help with journalist training. And maybe the journalists need to raise, if you don't have a formal peer review process before publication, then it's very wise for a journalist to seek the advice of a postdoc student or somebody with a PhD who's some training in critiquing other people's work, in using a theoretical framework like, Joanna Briggs. There are multiple frameworks you can use to assess the quality of whether a study's been done, which would include Nick's point that is the study population relevant to the population that you're trying to apply the results to, which is essential for any randomized controlled trial. I accept completely Nick's point. I have about 800 people with HIV, and I'm trying to get a recent phase 3 trial. Only 3 of them qualified because the thing was so tight and so narrow, which means the results only apply, as Nick quite correctly said, to perfect patients who are what the company want in the trial, so the results look good. So this you can look and see how are the patients recruited, and is that explicitly described? So obviously I'm an older fellow, so I'm thinking of evidence-based medicine and the classic McMaster Oxford sort of work on evidence-based medicine. But there are lots of frameworks for critiquing the rigor and quality of data that before a journalist writes about something that hasn't been peer reviewed, maybe should be asked to bring a critical framework to bear on a new piece of data rather than just accepting it verbatim. It's scientific preprints are not like Moses come down from with the 10 commandments from Mount Sinai carved in stone. We all know that, but maybe the journalists haven't fully realized that. So we need to bring that criticism, in healthy, positive, skeptical criticism, to bear on it.
Donald, you have your hand up. Please.
Just another, I think, example of a success story is that 10 years or so ago, different studies were showing that the number one source of information that medical students were using was Wikipedia. and everybody knew how, you know, unreliable that was. But rather than just saying, well, let's ban Wikipedia, they and Cochrane got together and figured out a way to ensure that any information that was medically related on Wikipedia was going to be properly critiqued and evaluated by people that Cochrane had trained. So Wikipedia changed their policy of just anybody can post anything they want because of the importance of this information. And I think it's a good example of getting the people with the knowledge and the training to engage with the people that are producing the popular you know, sources of information. And again, going both and rather than either or in the approach to improving what was available.
Simon, we're sort of close to running out of time. So
okay, well, I'll be very quick. I mean, that all works really well with what is known and with what has been established. But the kind of scenario that Maria identified earlier on, where science is doing its job and where there is a space between competing views in a fast-moving area of science, creates a space which both for scientists and for those who are observing the scientists, it's a space for disagreement. And of course, the quality of the disagreement will vary according to the quality of arguments that somebody is in a position to marshal. But in a fast-moving area where there is no certainty about the science, we can't be surprised that half-truths and half-baked arguments emerge.
I think we are over time already. Well, Sam, just quick, and then Nick also very quick, for just to finish it off.
To link our discussion about randomized controls back into COVID-19 vaccines, I would say how delightful it's been to see that the COVID-19 vaccines in clinical trials that have 90% success rate in a trial have turned out to have 90% success rate in Israel and Scotland, and healthcare workers who got them early on. So those are examples where whatever way they did the clinical trials, it's translated at least as well in the real world. And I was absolutely delighted about that. So just to bring it back to COVID-19 and vaccines and the problem where that was really, really fantastic to see the good news from Scotland and Israel in a real world.
Indeed. Nick?
Okay, very quickly, Bert. So I just think that I'd like to think that what Sam and Dónal said was very intuitive. But I think in each interaction we have to say key bono, who benefits, and certainly when it comes to politicians and journalists, not all, but some politicians just think of the next election, and that's what drives the motivation. And some journalists actually won't care what the science is. They'll only care about the popularity of their article, whether it's clicks on a website or whether it's advertisement that gets generated. So I do think that we do need, coming back to what we said earlier, I do think that we need some kind of ethics watchdog for the media.
Thank you all. I think it's been a pleasure to have you all and contributing to this discussion. It's now my pleasure to sort of thank you and the participants and those people who have sent in many questions. I'm afraid we haven't been able to answer them all. There's a large number of them. So with that, I'm just thanking you and thanking the RIA for running this, and with pleasure I'm sort of handing over to Oliver Feeney, who was the chair of the Symposium Organizing Committee. He is a researcher in the ethics of genome editing, linked both to the Institute of History and Ethics and History and Medicine in Tübingen in Germany, as well as a member of the Center for Bioethical Research and Analysis in NUI Galway. So Oliver, over to you.
Well, thanks very much, Bert. And what an amazing day. I mean, first of all, I just want to really thank people. I mean, many thanks are owed particularly to the excellent panelists and special guest contributors for their highly engaging and interesting discussions and reflections on these difficult bioethical challenges arising in contemporary Ireland and beyond. And when we're talking about ethical issues arising in the context of biology, medicine, or science, we're of course not only talking about what is ethical or not, but how do we foster and sustain such ethical discussions in the first place? And importantly, how do we manage those, as was mentioned, ethical and other disagreements when they inevitably arise? I believe that today we have seen some fine examples of insightful dialogue and robust disagreements, which were conducted nevertheless in an atmosphere of mutual respect and reciprocity, the core values indeed of genuine deliberative engagement. Now, as can be seen in various topics of discussion, from opportunities and challenges in new genomic technologies, trust in science and medicine, particularly in the context of vaccines, as well as in the range of public health responses to the COVID-19 pandemic, it's vital that we recognize, respect, and value the perspectives that each participant makes to the mutual collaboration of ethical deliberation in the public arena. Now, vital to this was our panel chairs, Professor Deirdre Madden, Dr. Derek Mitchell, Professor Bertrima, who carefully and fairly guided the discussions and invited comments and questions from all attending. And we were sorry that if we didn't have the time to respond to every question and comment, but we were deeply grateful for your thoughtful engagement with these difficult questions. And from the amount of times that we've seen thumbs up to the various comments and questions, it was something that was very enriching, I think, for ourselves and for the rest of attendees and panelists too. Now, it's also important to note that the chairs, panelists, and special contributors and the guests were involved in many preparations in advance of today. Given the current context, this time is valuable and in short supply, so it was much appreciated. Much longer preparations, time, and planning that went into the success of today's symposium was thanks to the incredibly collaborative, knowledgeable, and good-humoured members of the symposium organising committee. Professor Jane Farrer of Trinity, Professor David Smith at the Royal College of Surgeons in Ireland, Dr. Derek Mitchell at the Irish Platform for Patients, Organisations, Science and Industry, Dr. Joe McDonough from Technological University Dublin, Professor Donald Mahoney from Ohio State University and formerly our own DCU, Professor Deirdre Madden from UCC, as well as the support of the members of the Life and Medical Sciences Committee and its chair, Professor Mark Crowe, UCD. I'd also like to thank especially Professor Colin O'Moran, Professor Tara Moore, and Professor Jerry McKenna for their much appreciated support during these preparations. And we're also grateful for the funding we received from Trinity College Dublin, Queen's University Belfast, NUI Galway, NUI Maynooth, University of Limerick, and Technological University Dublin. Many thanks indeed to the staff of the Royal Irish Academy for their work and support, which was central to the success of this event, in particular to Teresa Gallagher and Karen Aiton in the programmes team. And we wish to thank the kind welcoming words of Dr. Mary Canning, President of the Royal Irish Academy, and many thanks also to today's ISL interpreters, Catherine White and Tony Dolan. And last but not least, we wish to thank all the attendees who joined us over the course of the three panels today. Over the course of today, we had over 400 people join us, which was an excellent turnout. And both your presence, your comments, your questions were central to the success of the event and crucial to the vital public nature that such bioethical discussions ideally take place within. Motivating this event was our belief that given the significant developments in biotechnology and medicine in recent years, some of which we touched upon today, there is an urgent need to rebuild a new national forum, be it council, be it committee, be it assemblies, juries, citizen juries, and so on, so that Ireland can more fully engage with important bioethical issues of the day in a way that's inclusive, public, and conducive to fostering widespread trust. And we hope this event will be part of a wider discussion that will be persuasive in highlighting the benefits and need of re-establishing a new national bioethics forum that is sustainable, securely funded, independent, transparent, multidisciplinary, and diverse in its membership, with functions both in advising government policy in areas of bioethical concern, as well as engaging deliberatively with the wider society to foster wider, respectful, and trust-building deliberative discussions. Now, just to finally add, recordings of each panel will be made available on the Royal Irish Academy website and YouTube afterwards, and a summary report and recommendations from the symposium will be published during the summer. So all that's left is thank you so much again, and all the very best.